The following podcast is part of a certified educational activity titled Defining and Delivering Person-Centric HIV Care in Key Populations. Access the entire activity and complete the post-test at peerview.com/JJX860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Jonathan Applebaum. I'm the Emeritus Professor at Florida State University College of Medicine and Medical Director, CarePoint Health and Wellness in Tallahassee, Florida. And I want to welcome you to Defining and Delivering Person-Centric HIV Care in Key Populations. Our goals for today are threefold. We want to augment your knowledge of person-centric care in your approach for people living with HIV. We want to equip you with strategies for providing care coordination to address the barriers that complicate the delivery of care to this population, and to provide guidance on recent clinical trial data and guideline recommendations for delivering person-centric care in people living with HIV. Our first module focuses on HIV in women. Let's talk first about HIV in transgender women. Gender-affirming hormone treatment, or GAT, is a core component of gender identity confirmation. It's essential for aligning the physical characteristics with the person's gender identity. It helps improve mental health, quality of life, and well-being for transgender individuals, and it's been shown to reduce gender dysphoria, which enhances the emotional and psychological stability. However, transgender people living with HIV may have reduced adherence to ART because they're concerned about the negative impact that GAT has on ART. So let's go to the guidelines. The DHHS recommendations for the use of ART in transgender people living with HIV there are three bullet points that are important to remember. ART is recommended for all transgender people living with HIV to improve their health and reduce the risk of HIV transmission to sexual partners. You'll notice that this is the same recommendation for anyone living with HIV. In addition, the DHH recommends that HIV care services should be provided in a gender-affirming care model to reduce any barriers to ART adherence and to maximize the likelihood of obtaining a suppressed viral load. Now, some ARVs may have PK interactions with GAT, and we'll talk about this in a little while. And as a result, clinical effects and hormone levels should be routinely monitored and with appropriate titrations of the gender-affirming medications as needed. This is a table looking at the common gender-affirming hormone therapies for transgender women. And there are several components to providing gender-affirming care. The primary component is the use of estrogens. Estrogens can be given in three different manners to cause feminization. There's an oral preparation, transdermal preparation, and intramuscular or subcutaneous preparations. Most patients prefer either the oral or the intramuscular injections. It's not important really to know specific doses, but I have provided dose ranges for the various preparations. In addition to estrogen therapy, many times we need to add an anti-androgen to help suppress testosterone production. The most commonly used anti-androgen is spironolactone. Other anti-androgens include cyproterone acetate, and there are several other anti-androgens. Occasionally, we use gonadotropin-releasing hormone agonists, but these are less commonly used. Overall, the effects of these are to cause more feminization, including redistribution of body fat, breast growth, decrease in muscle mass and strength, softening of the skin, and decrease in spontaneous erections. So one of the main concerns of folks living with HIV who are on GAT is the potential drug-drug interactions. And I think the bottom line is at the bottom of the slide, is that ARVs can be taken safely in conjunction with estradiol and spironolactone without losing the efficacy of either therapy. There are some minor drug-drug interactions, but if you prescribe the preferred regimens, ARV regimens, the drug-drug interactions are unlikely to occur. The ARVs that may decrease the concentrations of estrogen include ritonavir-boosted PIs and some of the older non-nucleoside reverse transcriptase inhibitors. And so some of the patients who are on any of these regimens may need to have their estrogen dose increase, but this can be checked and evaluated through periodic estradiol levels. The use of cobicistat boosted ARVs has an unclear effect on estradiol. What I've listed here are the standard physiologic reference ranges for estradiol and testosterone in GAT. We desire to keep the estradiol between 100 and 200 picograms per ml and testosterone less than 50 nanograms per deciliter. These are physiologic doses, not super physiologic doses. And it's important to understand and recognize that these levels are important guidelines. Other considerations for prescribing GAT in transgender women include concerns about osteoporosis and osteopenia, renal function, and cardiovascular disease. Cardiovascular disease is probably the most important concern, and in particular, those folks who smoke cigarettes and take estrogen are at much higher risk of potential side effects. Major side effect of estrogen is increased risk of venous thromboembolism, which would include deep venous thrombosis, pulmonary embolism, and ischemic stroke. Estrogen does have an effect on lipids, causing increase in triglycerides and HDL and lowering LDL. It's also important to note that our current cardiovascular risk calculators don't accurately account for transgender people. And so the world, the WPATH standards of care recommend that we use professional judgment and looking at other cardiovascular risk factors when considering the possibility of increased cardiovascular risk. So age, serum lipids, things like cigarette smoking. Regarding osteopenia and osteoporosis, the data here is a bit mixed. Estrogens have been associated with both an increase and a decrease in bone mineral density, but the risk seems to increase after gonadectomy, especially if the hormone regimens are decreased or stopped. And so guidelines around bone mineral density screening should be followed. The effects of GAT on muscle mass, which is a component of how we calculate GFR, may affect our estimation of renal function. Creatinine-based GFR calculations may overestimate GFR in transgender women, so recommendations are that maybe using other measures such as cystatin C to calculate GFR may be reasonable. In summary, we need to assure our trans patients living with HIV that taking antiretrovirals has little, if any, effect on their gender-affirming hormone therapy. Now let's talk about HIV and cisgender women. For women of potential childbearing potential, it's important to consider any woman of that age, to be potentially pregnant or could become pregnant. Important to remember that about 2/3 of all pregnancies are unplanned pregnancies. So as clinicians, we need to discuss reproductive goals regularly with our patients living with HIV who are of childbearing potential. It's best to achieve a undetectable viral load before conception, maintain that through pregnancy and at the time of delivery. And we know that this makes the risk of transmission of mother to child HIV very, very low. In addition, we need to be discussing with our pregnant patients their desire for and plans for infant feeding. So when we're selecting or modifying an ART regimen for people of childbearing potential, we need to consider the effectiveness. What are the potential changes in the ARV concentration in the second, third trimesters? What their hepatitis B status might be, because that might affect which drugs we prescribe. And then, of course, talking about the possibility of adverse outcomes for the pregnant person and their fetus. Because remember, we're treating two individuals instead of just one. So let's go back to the guidelines. The DHH guidance on ART selection in pregnancy is pretty explicit. They're saying that in most cases, people with HIV who are receiving ART and present for pregnancy care should continue their current ART provided it's working and it's tolerated and safe. That we need to be aware of the changes in physiology and volume distribution of drugs during pregnancy, because this is going to impact drug concentration and therefore the effectiveness in maintaining viral suppression. So pregnant people and their healthcare providers should review these impacts early in pregnancy, choosing when to start modifying and continuing their regimen. So if a person is ART naive prior to pregnancy, and we discover that they're living with HIV, it's important to start ART as soon as possible during pregnancy. And again, the things to consider is, what are the adverse drug effects and drug interactions? What's going to happen to the PK during pregnancy? Obviously, the convenience of drug combination, single dose tablet if possible. What is the available pregnancy safety and outcome data? What is the virologic efficacy? And then knowing what the patient's resistance test results are and any other comorbidities. So what I've listed here are the recommended and alternative initial ART regimens to use during pregnancy. The good news is that as we've gotten more data, you'll notice that the preferred and alternative regimens look very similar to the recommendations for those who aren't pregnant. So virtually all the NRTI backbone regimens are preferred. The integrase regimens are primarily dolutegravir, although there is growing evidence about the safety of bictegravir. And the PI regimens really have coalesced around boosted darunavir with ritonavir. You'll notice under the alternative regimens that efavirenz is listed under the NNRTIs, and many folks may remember there were times when, in the past, when we thought efavirenz was teratogenic, but that data has been updated, and now efavirenz has no teratogenic effect and is safe to use during pregnancy. There is insufficient data at this point to recommend doravirine. We need more information on that. And there are some ART that is not recommended during pregnancy. Long-acting cabotegravir rilpivirine is not recommended, mostly because we don't have a lot of data on that. And then any drug boosted with covicistat is not recommended because there's some concerns about safety in pregnant persons. We did mention about infant feeding in individuals with HIV. And sort of as a caveat, the DHH guidelines use the term breastfeeding, which is used to describe feeding a child's one's own milk, either directly or with expressed milk. But when counseling individuals about infant feeding, it's important to assess and use their preferred terminology. So some transgender and gender diverse individuals prefer the term chest feeding rather than breastfeeding. But looking at the guidelines, individuals with HIV who are on ART with a sustained undetectable viral load should be counseled about the options of formula feeding, use of bank donor milk, or breastfeeding. Okay. And those who choose breastfeeding should be supported in this decision. And this is a relatively recent change in the guidelines. Replacement feeding with formula or banked pasteurized donor human milk is recommended for people who are not on ART or don't have a suppressed viral load during pregnancy, at least as a minimum through the third trimester, as well as at delivery. So folks who have a detectable viral load for any reason at the time of delivery should be counseled that formula or bank milk is probably better. And then for individuals who choose to use formula feed, they should be supported in this decision. I think the summary for this section is that we should consider any woman of childbearing potential to be potentially pregnant, and we need to provide pre-conception counseling about how to manage their HIV during and after pregnancy. Our next module focuses on HIV in people of color. This chapter will cover HIV in women of color as well as Black and Latino men who have sex with men. So we're going to start off with HIV and women of color. The bar graph on the right shows the racial and ethnic distribution of the U.S. female population. And you'll note that about 60% of women in this country are white, and about 13% Black or African American, 19% are Hispanic or Latino. The bar graph on the left shows the racial and ethnic distribution of women who were newly diagnosed with HIV in 2022, which is the last year we have data. And you'll notice that 50% of the women diagnosed were Black or African American, 20% were Hispanic and Latino. And obviously, you can see that there is a huge disparity in the proportion of women who were diagnosed with HIV in 2022. And this is something we've known for a while. Women of color, especially Black women, are disproportionately affected by HIV, and even more so in the southeastern and southern U.S. compared to other U.S. locations. In 2021, HIV was the 9th leading cause of death for Black women between 25 and 34. HIV transmission is primarily linked to high-risk heterosexual sex. In other words, the women are becoming infected by their HIV-infected male partners. And a theme you'll hear over and over again is that things like stigma, discrimination, poverty, and poor access to healthcare really are contributing to the disproportionate HIV burden in this population. Now, turning to men of color who have sex with men, the pie chart on the left shows the distribution by risk factor of HIV, new HIV infections in 2022. 2/3 of the new infections are from men who have sex with men, and 1/3 from other risk populations. So in 2022, among all men who have sex with men, about over a third were Black Americans who were infected, and of those, 43% occurred in the age group of 25 to 34. Of the men who have sex with men in 2022, 38% were Hispanic Latino, and a little under 50% were occurred in those aged between 25 and 34. So with that sort of as a backdrop, there is some good news here. And in the 4-year period between 2018 and 2022, HIV infections did decrease by 16% among Black African American men who have sex with men. So there is some potentially good news here. So what are some of the factors that lead to this disparity? And I think this is a list here. It's not in any particular order. And I'll, from my own personal experience, I think stigma, internalized homophobia is probably at the top, but other things, just lack of awareness about HIV. Uh, the prevalence of sexually transmitted diseases, not fully understanding that HIV itself is a sexually transmitted infection. There are sexual networks where groups tend to pass HIV, the infection among themselves. There's issues around disclosure and potential loss of social and family support. The social determinants play a huge role, things like housing insecurity, food insecurity, as well as lack of HIV prevention education. And then finally, lack of access to preventative services and treatment. There was a semi-structured interview study done among Black and Latino men who have sex with men in New York, and that study really did identify stigma as the main driver of HIV risk among this population. And there were some sub themes that came out from that interview, those interviews. One is the issues around homophobia in the Black and Latino communities. One of the participants said that there's the whole machismo in the Latin and Black community and growing up, as my grandparents are from Puerto Rico and growing up in a Hispanic background, how dare you say that you're gay? It was hard for me to even come out as gay. I didn't even tell my mother until I was almost 30 years old. That person was 36. Other things that came out were the fear of losing support from family and friends. So one quote was, I think that in the Black community, people are so scared to say I'm a homosexual. Like even myself, I haven't said it out loud. I feel that if I say it out loud, I'm going to lose so many friends. Maybe one day I move across the country to be a whole different person, to be myself. And then finally, lack of support leading to self-esteem, that men share that when you do not care about yourself, you don't care about what you do. So as a summary to this section, I think the one point I would take away is that Black and Latino men and women both are disproportionately affected by HIV, out of proportion to their population in this country. So in this chapter, we're going to discuss HIV in immigrant populations. So about 14% of immigrants who come into the United States arrive in countries with a high HIV prevalence of more than 5%. And it's even important to know that prior to resettlement in the U.S., immigrants may have traveled to or lived in other countries with high HIV prevalence. So immigrants are a vulnerable population and may be victims of physical and sexual violence and may therefore be at risk of getting HIV through sexual assault, blood transfusions, medical procedures, or drug use. And the immigrants don't always disclose these during their initial intake assessments. So going back to the guidelines around HIV screening for refugees entering the United States, and I'll preface this by saying the guidelines are not much different than for the general population in the United States. So the current CDC guidelines recommend HIV screening for all persons between 13 and 64 years, but the guidelines are in the process of being updated, and the draft guidelines will eliminate the upper age group. So basically, the draft guidelines are saying that anyone aged 13 and above should be screened. Guidelines also recommend screening of all refugees on arrival, regardless of age, especially in cases of children where we don't know what the maternal HIV status was. In addition, there's a recommendation that they be rescreened in 3 to 6 months following resettlement for those who might have had a recent exposure or high-risk activity. And also important to know historically that refugees who arrived in the United States before 2009 were not tested prior to arrival in the U.S. So what are some of the barriers to HIV diagnosis and care in this population? I think the biggest issue now is legal status, and especially with concerns about undocumented immigrants in the United States and what their legal and status will be in the future. I think that's the biggest barrier that prevents diagnosis and care. In addition, there may be language barriers. Like you've heard before, stigma and discrimination play a role. These folks may have not have health insurance, particularly those living in states that did not adopt a Medicaid expansion. And then they may have a lack of education about HIV. What are the HIV risk factors that may promote infection? This slide shows the insurance status of immigrant populations, and it's probably no surprise that about half of undocumented immigrants lack health insurance, and under 20% of lawfully present immigrants lack health insurance, whereas only about 8% of U.S.-born citizens lack health insurance. So there is an issue around access to insurance. And this slide talks about the access to healthcare, and the green bars are likely undocumented immigrants, and the darker bars are the naturalized citizens. And again, I don't think this will be a surprise to people that undocumented immigrants are more likely to use the emergency room as a source of care and not have a regular physician visit in the past year, or have stopped or postponed care in the past year. So what are some of the facilitators to diagnose HIV and engage this group in care? So on the left, we've listed the continuum of care for HIV, that we seek and test for HIV, link the person to care, make sure they engage in care and retain in care, and ultimately achieve virologic suppression. So to facilitate this, things like additional social support, having a good patient-provider relationship, having access to services like housing, employment, food, health insurance. There's a huge importance to having a community or religious outreach, and then providing culturally sensitive care. So as a summary to this section, immigrants are more likely to lack testing and access to care. And some of this may be due to stigma, but also due to fear of discovery of their immigration status. Our final module focuses on HIV at each end of the age spectrum, adolescents and older adults. In this chapter, we're going to discuss HIV in adolescents and young adults. So in the United States in 2021, about a fifth of all new HIV diagnoses were among people aged 13 to 24, and 50% of those don't even know that they have HIV. This group also has less access to preventative measures and are less likely to be prescribed PrEP. So there's a decreased use of condoms, down to 52% from 60% over a 10-year period. Substance use may lead to high-risk behaviors and activities, and adolescents who identify as LGBTQ+ are at risk of negative health outcomes due to their increased chance of sexual violence and more illegal drug use as compared to their heterosexual peers. So when we talk about HIV care, we talk about the HIV care continuum, and the data on adolescents from 13 urban centers shows that if you take the population 100% who are infected, only about three-quarters were linked to care. About 60% remained engaged or were engaged in care, but only about a third of this group were retained in care. And at the end, unfortunately, only about 12% had a sustained, had a suppressed viral load. When we look at the care continuum for adults in the United States, we see a different story where we see at the end about 57% have viral suppression. And if you look at other cohorts like Ryan White, patients who are getting care through Ryan White care centers, the viral suppression rate is just under 90%. So the adolescents are really a very high risk group. I think we can divide adolescents who are living with HIV into two groups, those who are perinatally acquired and those who acquired HIV later on. And the reason for this is that their immune systems are different. The immune system in those who required HIV perinatally have more immune dysregulation and damage to the immune cells. They're at also greater risk for neurocognitive deficits. They've been living honestly their entire life with lifelong stigma and identity related to having HIV, and they have a higher likelihood of comorbidities related to long-term ART use, chronic immune activation, and potentially more long-term effects from previous ARVs that were used. Those who acquire it later in their life, because they have had HIV for a shorter amount of time, that the immune system involvement tends to be less severe. They're less likely to have neurocognitive deficits. They may struggle with a shift in identity when they're diagnosed, but their comorbidities may be fewer or less severe depending upon when they were diagnosed and when they were started on ART. One of the biggest issues, though, is transition of care from a adolescent, pediatric or adolescent care model to an adult care model. And this chart describes the EPIS framework, EPIS standing for exploration, preparation, implementation, and sustainment. Basically, it's a roadmap of how to make a successful transition from adolescent care to adult care, with things like making sure there's a warm handoff, making sure that the care is integrated between adult and pediatrics, and including more social support. So the barriers to adolescent to adult care transitions, we're going to look at the patient and the provider's perspective. The patient's perspective is they have to now trust a new provider. They may have developed a long-term relationship with their pediatric team. They may face communication issues. There's clearly a difference in the adult healthcare system compared to the pediatric healthcare system, and so there may be some difficulty adjusting. They may have problems with appointment scheduling, and they may lack transportation. From the point of view of the provider, providers may be reluctant to transition the patient. They may be unwilling to take on the patient. There may be a lack of accessibility of adult providers. They may find that the patient is reluctant to tell their story. They've told it so many times. They're having to deal with a forced increase in autonomy. They may find that the patient is less willing to trust them because they're a new provider, and they may feel that the patient lacks maturity to take on the responsibilities of being an adult. So what are some of the things that can facilitate this transition? Well, from the patient's perspective, getting them to trust the adult provider, maybe having a social worker or patient navigator, case manager to help, a warm handoff between the teams. And I think this is probably one of the most important factors, making sure that there's a referral in place, maybe maintaining a dual relationship with both the pediatric team and the adult team for a little while, and having the new provider in the same location. From the provider's perspective, again, having this social worker, case manager, patient navigator person, preparing for the transition, working in the same location, having a warm handoff, giving the patient time to adjust to the diagnosis, and working on developing health literacy. So I think that the takeaway from this section is that transitioning an adolescent to an adult does require planning on the part of the pediatric team and the adult team. We're going to discuss HIV in older adults. So to give you some information on the demographics, more than half of Americans living with HIV are 50 years of age and older. Older adults with HIV are more likely to have more than one chronic health condition, and things like diabetes, cardiometabolic disease, osteoporosis. Patients who are 60 years of age and older living with HIV have an average of 4 comorbid non-HIV related conditions. Chronic inflammation and immune dysregulation, even in the presence of ART and an undetectable viral load, are really central to what we think of as accelerated aging observed in persons living with HIV. 60% of people living with HIV age 65 and older are living with a disability, and older adults who have HIV may have unique mental health needs related to depression and cognitive disorders, and this can be further exacerbated by things like stigma, social isolation, and loneliness, which is becoming more important, and then the lack of social support. And what we've listed here are some health issues in people living who are aging with HIV, and we've kind of divided it into medical and psychosocial stressors. So on the medical side, patients may be living with multimorbidity, which is really the interaction of several chronic conditions where the effect of one or the treatment of one can affect the others. Polypharmacy, which we'll talk about in a minute, falls, frailty, cognitive decline. Some of the psychosocial stressors, underlying mental health conditions, the presence of substance use, stigma, and then the importance of loneliness and social isolation as factors. So talking about some of the common comorbidities, cardiovascular and kidney disease, again, as I stressed before, for many of these issues, the ongoing chronic inflammation is really central to the aging process and pathogenesis of HIV-associated comorbidities. Some of the common cardiac comorbidities include ART-associated dyslipidemia, atherosclerotic cardiovascular disease, and arrhythmias. And some of the common kidney comorbidities are really, we think now, are caused more by non-related HIV conditions, such as CKD, underlying diabetes or hypertension. The other kidney conditions are much rarer as causes of kidney disease in older people with HIV. So osteoporosis treatment in older people aging with HIV, the recommendations are that those at risk for fracture include those who previously had a fragility fracture, those who on a DEXA scan have a T-score of less than or equal to minus 2.5 at either the spine, the hip, or the femoral neck in postmenopausal women and men age 50 or above. And those who, in addition, have a T-score between minus 1 and minus 2.5 and a FRAX score of more than 20%. And then if no bone mineral density is available, just having a FRAX score of greater than or equal to 20%. It's important to understand what the guidelines recommend, which is that anyone with HIV age 15 over should have a screening for osteoporosis. Part of the evaluation is to look for secondary causes of osteoporosis, to really optimize their calcium and vitamin D intake, encourage physical activity, particularly weight-bearing activity, smoking cessation, and to moderate alcohol use. Bisphosphonates are advised, and by the same guidelines as in folks who are not living with HIV, either weekly oral adendronate or yearly zoledronic acid. And it's important to reassess the bisphosphonate use in usually 3 to 5 years due to potential adverse effects of prolonged bone turnover suppression. It's important to note that the FRAX score does not account for HIV, which many people believe is a secondary cause of osteoporosis. So the FRAX score may underestimate the fracture risk. As far as ART considerations, it's important to avoid first-line regimens that include TDF or PI-based therapies, and consider switching ARBs in patients who are already on those regimens. TAF is okay to use because it has less effect on bone mineral density. Polypharmacy is defined as the use of multiple medications. Geriatricians define it as taking 5 or more medications. And polypharmacy is associated with lack of decreased adherence, increased risk of adverse effects, increased risk of drug interactions, increased risk of geriatric-related syndromes such as falls and frailty, and it's associated with an increased risk of mortality. So polypharmacy is a strong predictor of fall risk, drug interactions, and clinically relevant adverse effects. And important to remember that drug interaction effects may decrease the effectiveness of the HIV medications or increase toxicity and adverse effects. And there is a dose response association with all-cause mortality and cardiovascular related mortality. Frailty is another issue we see in older people living with HIV, and the clinical manifestations include decreased muscle mass and strength, fatigue and poor endurance, cognitive decline, and the risk of frequent hospitalizations and infections. So what are some of the risk factors? Again, going back to chronic inflammation, the increased number of comorbidities, long-term ART use and its impact on things like bone density, renal function, and cardiometabolic health. And then even stigma, isolation, and access to healthcare resources are risk factors. As far as management, this may be a time to get the assistance of a geriatrician to do a comprehensive geriatric assessment. Recommendations are to screen patients who are 50 years of age and older every 1 to 2 years for frailty using some of the measures such as the Frail scale. And if patients are robust, then maybe you don't need to screen them as often. The way to intervene would be to address modifiable risk factors such as increasing physical activity, maximizing a nutritious diet, having the patient stop smoking, and avoid substance use, or have the patient seek substance use counseling. And obviously to manage and reduce polypharmacy. The good news is that there are several pharmacologic agents that are in clinical trials for treatment and prevention of frailty. The 4th annual State of Aging with HIV National Survey outlined some of the mental health challenges in persons living with HIV, persons living with HIV, with 76 reporting moderate to high mental health stress in the past 6 months. 40% reported daily substance use. That mental health diagnosis was the second most common comorbidity impacting older persons with HIV, and almost 50% felt lonely or isolated often or all the time. One of the respondents noted that they felt they were aging faster than their peers, having issues with hearing, vision, joint pain, increase in belly fat, loss of motivation, and memory issues. Another respondent talked about the aspects of daily living impacted by HIV were mostly mental health and social interactions, particularly navigating stigma and managing the stress related to long-term treatment. The summary for this section is for providers to be aware of the impact of comorbidities, polypharmacy, frailty on the care of older patients living with HIV.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/JJX860.